a big story, a huge story. So our next speaker is Fortune Effiong. He's from the University of Calabar Teaching Hospital in Nigeria. He's a recent medical lab scientist and a budding global health researcher and leader. His focus in global health revolves around influencing the attainment of universal health coverage in the global south through research. So please come along and share your work on cost effectiveness.
Hello, everyone. I know cost effectiveness analysis is not usually the highlight of anyone's conference day, but I promise this one has some global health drama and some very expensive math. So in summary, what question did we ask? We asked ourselves the question, does Cabotegravir long-acting injectable for PrEP offer a good value for money in comparison to oral PrEP? And what did we realize? We found that, yes, Cabotegravir is really clinically promising, but its cost effectiveness is uncertain, especially at current prices. Understanding when and where CAB is cost effective can guide smarter, more equitable policy decisions. So we know that PrEP is very effective in reducing HIV acquisition by almost 90%, and oral PrEP, which recommended to be taken daily, and ruled out some years ago, shows limited effectiveness in real-world settings because of poor adherence and high discontinuation rates. However, a more recent PrEP option, Cabotegravir, shows some clinical promise, but its effectiveness across settings remains uncertain. We conducted a systematic review to synthesize evidence to understand the cost effectiveness of Cabotegravir compared to oral PrEP across different settings and populations. We followed the 2022 PRISMA guideline, and out of 19 studies that came from our initial search, that are just very few modeling studies, we included 5 studies. And for eligibility criteria, we're interested in studies that were conducted in populations that had high risks of HIV, studies with CAB as an intervention, and of course, oral PrEP as a comparator, or no PrEP. Of course, we're interested in number of HIV infections averted, a number of deaths averted, as well as the incremental cost effectiveness ratio. And because this is a systematic review of modeling studies, we only included modeling studies. So very briefly, we'd like to touch base on ISA. ISA tells us how much we're paying for a unit of health, and if that cost is reasonable, then that investment is cost effective. So the way we interpret ISA is that we compare it to our willingness to pay threshold, and if the ISA is below that willingness to pay threshold, then we can say the intervention is cost effective. So this is a summary of our studies. 3 of them were conducted in South Africa, 1 in the US, and the other one was a multinational study in Australia, Thailand, and China. So what did we find? First, in the study among high-risk South African women, we saw that CAB has a ISA value of $150, and if you compare that to the threshold, which is just by the side, 7,000, it is way below that threshold. In this study, it was considered highly cost-effective. However, when we did sensitivity analysis to see what could happen if the price increased or come down, we realized that when the price of Capla was reduced to $9 per month, Capla was not just cost-effective, but very cost-saving. But then when it increased to like $28, it was no longer cost-effective compared to oral PrEP. In a study among injectable contraceptive users, Capla had an ISA of 1,113, and that was considered potentially cost-effective. And in the what-if scenario, the moment ART coverage increased above 85%, and the cost of the drug was more than $16 a year, it was no longer cost-effective. For the study on heterosexual men, CAP was not considered cost-effective at the current price. But then we saw that when it was administered to populations with a slightly higher incidence, it was considered marginally cost-effective. The other two studies, one from the US, among men who sleep with men and transgender women, and among men who sleep with men in Thailand, Australia, and China, Kabla was not considered cost-effective at its current price. But then, for the study in the Asia-Pacific region, we realized that once the price of Kabla was reduced by 66%, 88%, and 24%, respectively, it became cost-effective. However, there are limitations to the modeling studies. Of course, they are modeling studies, so they deal with assumptions which are not reflective of what happens in a real-world setting. And of course, they use varying cost-effectiveness thresholds, so it's a bit difficult to compare sometimes. What does this mean? How is it important for us as researchers? And what lessons can we take from this study? The first is what we have been saying from the beginning of this conference. We have to come up with innovative financing methods on how we can reduce the cost of Kabla. We've suggested a few here: tiered pricing, patient patent waivers, and pooled country procurement. We could also explore outcome-based funding and concessionary loans by developmental banks. Very importantly, research in the future could look into self-injection models, and maybe auto-injectors and patches, and models to increase access of Kabla in the community. Because we realize that when this is done, it reduces the programmatic cost of administering Kabla. Like we've been saying, integration from the beginning of the conference, Kabla should not be left behind. We realized from one of the studies that once Kabla was integrated with family planning services for among injectable contraceptive users, the programmatic cost of implementing Kabla was significantly reduced. Also very importantly, we've seen that when Kabla is targeted at populations with high HIV incidence and populations with poor adherence to PrEP, or to oral PrEP, it became even more cost effective. Finally, it's very important for us in the long run, and of course in the coming days, weeks, and months, to strengthen implementation research to monitor, of course, the retention, acceptability, drug effectiveness, and long-term effectiveness of Kabla. So if we're going to forget anything in this presentation, let us remember that Kabla is really a promising PrEP option. It averts more HIV infections and death compared to oral PrEP. However, talking about value for money, cost effectiveness, is it cost effective? Yes, under certain scenarios. It is very sensitive to the price of Kabla, the incidence of HIV, the coverage of ART, and the program design. So for we as policymakers and researchers, we have to explore innovative financing methods that can reduce the cost of Kabla. So I'd like to thank my co-investigators, my organization, the Systematic Reviews Network, and the University of Calabar Teaching Hospital. I also like to thank the fashion designer who made this nice Nigerian outfit I'm putting on. Thank you.